Welcome to PopHealth Week, streaming live on Healthcare Now Radio. I'm Craig Masters, co-founder and executive producer. Joining me in the virtual studio is partner and co-founder Fred Goldstein, lead host and president at Accountable Health, LLC. PopHealth Week is your destination for unfiltered conversations with the visionaries driving population health forward. Whether you're a payer, provider, patient vendor, or policymaker, this is your go-to hub for fresh strategies and insights into population health best practices. Want to stay connected? Visit popupstudio.productions or message me on Twitter via @GregMastersMPH, and that's Greg with 2 G's. And do follow the show at PopHealthWeek. To reach Fred direct, visit www.accountablehealthllc.com. With no further delay, Fred, who's in the seat today?
Thanks so much, Greg. And today I've got Drs. O'Hara and Dr. Mann to speak about preventive medicine. So let's begin. Welcome, Dr. O'Hara.
Thank you so much, Fred. I'm happy to be here. I think, this topic is something that we all continuously want to figure out how to get the word out about. So I'm super excited to be here today.
Well, it's really a pleasure to have you. And welcome as well, Dr. Mann.
Good morning. Great to be with you.
Yeah, thank you as well for joining. So let's begin with you, Dr. O'Hara. Tell us a little bit about your background.
Sure, absolutely. Well, originally from St. Louis, Missouri, and currently residing here now after almost 30 years of being away. Did my training for medical school at Meharry Medical College and stayed on there because what we probably will get into a little bit today, there was a preventive medicine residency there. So did my both my medical school training and my my residency training at Meharry Medical College. Then went on to work at Concentra for a little bit after completing occupational and environmental medicine fellowship. But that was quickly changed by going into as a faculty at Meharry because they had a need for additional faculty within the programs. I stayed there for about 8.5 years, I think, maybe longer. Went down into like part-time role, but then took on some additional work in Decatur, Illinois as their medical director for occupational medicine. And then I went to Decatur, Illinois to serve as their medical director for the Memorial Occupational Health Clinic, which was a system of hospitals within that area in Illinois. After that, we moved back to St. Louis, got closer to family with 3 kids, needing additional help. So got to St. Louis, thankfully, with a role at the VA as their chief of comp and pen or compensation and pension, and have been doing that since 2024. So happy to be here. In addition, I also serve as the chair of the American Board of Preventive Medicine currently. My term will end in 2027. So it's been a very rewarding experience and just looking forward to what comes next and continuing to help in my specialty.
Well, that's fantastic, and especially we'll get into, obviously, the preventive medicine component in the board. How about you, Dr. Mann?
Yeah, so I'm a physician with my certification in public health and general preventive medicine. I'm from a small town in South Mississippi. Parents both taught at a local community college. They taught a combination of chemistry, physics, and biology. So a lot of kind of pre-health stuff. And so I kind of grew up on that campus, did my couple of years at junior college where they taught, and then went to college at a small school in sort of the northwestern Mississippi, Delta State University, and then medical school at the University of Mississippi Medical Center in Jackson. After I finished that, I did a transitional year at a hospital that unfortunately no longer exists in Birmingham, Caraway Methodist Medical Center. It was really, really neat place with a cool history. And after that, did my preventive medicine residency at University of South Carolina. After I graduated that, I spent a couple of years working for a small nonprofit doing research and advocacy in Texas, and then sort of got recruited back by some of the faculty at South Carolina to become a faculty member there. Did research, student and employee health work, some teaching with medical students and residents, and then a few years after that became the residency director in public health and general preventive medicine. Did that for about 10 years. Then got actually kind of recruited to come back to Mississippi in 2015 to restart the Department of Preventive Medicine that had existed for about 50 years, but had been shut down in either 2007 or 2008. And so they were ready at that time to reopen that. And so I came here then, and I've been here 11 years since. So it's been interesting being a founding chair and kind of getting to start some other things along the way, and been a lot of fun. I also know Heather, or Dr. O'Hara, I should say, pretty well. We met way back in the day when we were both new residency directors at some of the preventive medicine conferences. But more recently, we've served together with the Preventive Medicine Review Committee, which is the accreditation body for all the preventive medicine residencies, and that includes general preventive medicine that I'm in, occupational environmental medicine, and also aerospace medicine. I serve as the chair of that committee, and I'll be in that role for one more year. And Dr. O'Hara was the vice chair of that committee for several years. She just rotated off of that around the same time that she became the president of the American board. So we're reaching that stage of our careers where we sort of kind of know all the people in our small little realm, which is kind of an interesting transition career-wise.
Yeah, it's fantastic. And I've really enjoyed working with you, Dr. Mann, at the School of Population Health as well. Appreciate that. Let's begin with you, Dr. O'Hara. Since you are the chair of the American College of Preventive Medicine, could you talk about what is preventive medicine?
Sure. I think that is a question that is difficult for a lot of us to respond to because we cover so much. As Josh kind of alluded to, so under the preventive medicine umbrella, we have three specialties: public health, general preventive medicine, occupational environmental medicine, and aerospace medicine. But it doesn't stop there. We also have four subspecialties. So there's clinical informatics, addiction medicine, healthcare administration, leadership and management, and even undersea and hyperbaric medicine. So when you have this wide swath of, specialties and subspecialties that all have their unique foci, it gets difficult to make sure that everybody feels represented. And so I think in general terms, preventive medicine is there for prevention. And so when you look at it from a perspective of public health and general preventive medicine, you're looking at population health. You're looking at, how even individual clinical care of patients affects the population. When you're in occupational environmental medicine, it's still prevention. It's prevention of workplace injuries, of bloodborne pathogens, of the things that the workers do that could be potentially harmful to their health, that we want to make sure they come to work and are able to leave work maintaining or improving their own health. And then with aerospace medicine, of course, with making sure that the flight space area is healthy, is the people that are going up are able to perform the functions that they need to. So it's encompassing that whole perspective of work on the ground as far as aerospace medicine is concerned and in space. But it gets really confusing. So all of those things, you can see prevention working within them. It gets confusing when you get into clinical informatics, addiction medicine, healthcare, we'll call it home, healthcare administration, leadership and management, and then undersea and hyperbaric, because it's not as clearly seen. So we want to, but to that end, everybody in those areas works from some level of prevention. So clinical informatics, they are looking at hospital systems. They're looking at big data to understand where we are faltering in what we need to do for our populations and how to improve those systems. With addiction medicine, trying to help people come away from, use of those substances and help their lives to be healthier to prevent future issues from occurring. With undersea and hyperbaric medicine, they're helping people to stay healthy and not have to deal with the harmful effects that could occur with diving and other things like that. And then, of course, with home, that's hospital administration. And Fred, from what I've just learned, of your background, you can understand how prevention is absolutely a key component in ensuring that the health systems that we have and the management that is in place come from that perspective of wanting to prevent the hospital system from failing our public. So, as you can see, overall, it's about prevention in individual, community, workplace, and populations across the board within all of our specialties and subspecialties.
Yes, it's really fascinating. I think about this and I say to myself, well, prevention, and we've talked about it a lot in population health. This is where we really need to move to. We need to move upstream. So, Dr. Mann, I'm going to throw this one to you. When I've never been referred to a preventive medicine specialist, so how do you integrate in the system?
Yeah, that's a really good question. And building off what Dr. O'Hara was saying, to back up a little, my perspective of most of the preventive medicine specialties is I think you have to think of them as hybrids. We really are, most of us in these fields are hybrids. We went to medical school probably with no understanding of anything about public health or population health or any particular knowledge about prevention or even that there was a field like this. Most of us sort of stumble into it. So we went to medical school typically thinking we would come out the other end and be the same kind of doctors we saw growing up, a pediatrician or a family medicine doctor or an OBGYN or an internist or whatever. But then somewhere along the way, we sort of discovered this issue of the gaps related to prevention, and the needs there. And then also the importance of systems. And in my mind, it's the systems aspect that's pretty unique to most preventive medicine physicians. And so most of us, whether we're in the occupational environmental space, the general preventive medicine / public health space, or the aerospace medicine space, or even the subspecialists, most of us, when we finish, don't really aspire to be full-time clinicians. Most of us aspire to be part-time clinicians and then integrate that with system level work. And the system can be a hospital system or a health insurance system or a public health system or a large employer or even a corporate health kind of system. And so that's why you don't see a ton of just sort of standalone preventive medicine clinics. Is our reason for being really is more about integration. And so you may see a preventive medicine physician working in, a federally qualified health center alongside people that are trained in internal medicine or family medicine, things like that. And they may be doing some outpatient primary care, but they're probably also having a significant portion of their time dedicated towards helping to set up systems to track the performance metrics, helping come up with solutions to improve, gaps in preventive services and things like that. And the same with the occupational environmental. You may have a physician who runs an occupational health clinic within a large factory, and they may spend some portion of their time, they almost certainly will spend some portion of their time treating employees who have back injuries or experience a cut, or if it's a healthcare setting, experience a needle stick, things like that. But they'll also probably spend a lot of their time working on policies, doing kind of root cause analyses, analyzing data to say, okay, what areas of our factory are experiencing the most injuries and what kinds of injuries are they experiencing and what can we do on the front end to change that. You'll see folks that work in health departments, state health departments as state epidemiologists or state health officers or in federal public health agencies, and a lot of military, especially in the aerospace medicine space, a lot of military. But also if you go to an occupational environmental medicine conference or a public health and general preventive medicine conference, you'll see a lot of Prev Med folks. And again, it's that same model where they're responsible for trying to keep the entire fighting force healthy in an integrative way, where they're probably doing some clinical care, treating soldiers or sailors who get injuries, but probably focus more on the systems level aspects of how we prevent those things. So I don't even remember the question you asked me, Fred, but I think I may have kind of answered it. I think you asked why you don't usually see like an independent preventive medicine clinic, and that's the reason why it tends to be integrated in these larger systems.
Yeah. Anything you'd like to add, Dr. O'Hara?
No, I think that Dr. Mann's explanation of that was extremely clear. And to that end, it's not to suggest that there's not a potential space forward where we could have something like that. I think, and Dr. Mann, you let me know if you don't agree, and that's okay. But I do think that we can be extremely helpful partners in the primary care space. And I don't think we have a good setup yet. Maybe there might be one-offs here and there, but not a good setup yet where preventive medicine physicians actually can serve in that capacity. And I think it does go back to just the credentialing component, the understanding of what it is that we can do so that clinics know how to actually use us.
Yeah, I agree with that. And we've had several of our residency graduates in recent years take primary care jobs and where they're really functioning as outpatient primary care. Typically, most commonly that I've seen with federally qualified health centers. And even in that setting, they may be majority primary care, but usually, at least in our small sample size from our program, usually they also have an add-on, like a value added of something to do with the quality metrics and the quality improvement and care management. So they're kind of integrating that, but a lot of it depends on what their background was pre-residency. I think as far as getting more like a traditional primary care role, what our residencies don't typically have is much, if any, hospital-based medicine. So typically, folks, the straightforward pathway is you do a preliminary year or a transitional year, which is what I did, and then you do the Prev Med part of it for 2 more years. And so that preliminary year is heavily hospital based, but then the 2 years of general Prev Med or occupational medicine or aerospace typically don't really have a hospital based component. And so if you're talking about a primary care job where they want you to also, round in the hospital, that's where our folks tend to be at a disadvantage. But then again, where we have the advantage is all of this systems based knowledge and prevention knowledge. And then one other thing to add too, there's a component of our training. It's included in our accreditation requirements, and it's also part of the board exam, is what's called lifestyle medicine. The American College of Lifestyle Medicine is a separate entity. It's not, quote unquote, under preventive medicine, but a lot of preventive medicine programs, including ours in Mississippi, have a heavy emphasis on lifestyle medicine. And we actually do have a lifestyle medicine clinic in my department here. We're very proud of it. It's very impactful. We staff it primarily with nurse practitioners, and our residents rotate there. I see patients half a day a week. We have not sort of cracked the nut in our market, at least, of how to make that sort of a fully self-funding mechanism that would pay for a physician salary. It works out pretty well with, and we love our nurse practitioners. So, but just the fact of the market is that the salaries are lower than they are for physicians. But because lifestyle medicine is not procedurally based, and so many, the procedures tend to pay a lot more, it's hard to make the dollars work unless you're in a setting that's much more managed care penetrated, or sort of a self-contained employer based, coverage model, that kind of thing. That's where you'll see these full-time lifestyle medicine clinics. And I am aware of some, definitely, but Mississippi is just much more of a kind of traditional fee-for-service model. But I think that lifestyle medicine aspect, and again, it's not unique to preventive medicine. You'll see family medicine folks and internists and others that are also certified in lifestyle medicine, but it lines up really well with the philosophies of preventive medicine. And I'm hoping that over the next 5-10 years, we'll see growth in that arena.
Just tuning in? You're listening to PopHealth Week on Healthcare Now Radio with host Fred Goldstein, president of Accountable Health LLC. Stay tuned for the rest of the story.
Absolutely. It's a critical area. And actually a good colleague of mine who passed away in the last year, Dexter Sherney, was the president of the American College of Lifestyle Medicine. We worked together on a number of different projects. Just an incredible individual. And what I think about is that, as you both have talked about this, and the issue you just raised around fee-for-service medicine and how do you get this paid, is when we really begin to say, how do we create a healthier population? How do we move upstream? This whole concept of preventive medicine and what you talked about in terms of creating the structural systems within an organization to do some of these things becomes critical as we move to more value-based care payments and suddenly go to a capitated model. Well, if you prevent people from having illness, you're obviously going to do a lot better. So do you see opportunities there and beginning to have more of these other groups potentially look to preventive medicine as a way to integrate in these structural changes to make their programs much more upstream oriented?
I'll take a quick crack at that,
Sure.
and then Dr. O'Hara can fill in. So this reminds me, it's kind of a joke that I like to tell, and I hope that this won't be offensive at all to Dr. O'Hara, but I think back to when about 1994 or 1995, when I told my parents that I decided I wanted to do preventive medicine, and they said, "What's that?" And I had to have this basically same conversation with them, and I told them, "Don't worry, it's the wave of the future." So what I like to say about preventive medicine is it's been the wave of the future for at least 3 decades.
That sounds like a lot of things in healthcare, interestingly enough. But go ahead, Dr. O'Hara.
So I definitely think so I guess I'll pause for a second and go kind of back. I think that the need for prevention to be at the heart of whatever we do that has been there for years, decades, millennia, I don't know. But either way it goes, so with the current system that is kind of pushing more for some things to occur around healthier lifestyles, I do think that that concept of healthier lifestyles is a potential opportunity for preventive medicine. But I do think we need to make sure that things that we're suggesting remain evidence-based and, are following the guidelines of what we know to be helpful in our communities, in our populations. So that's where I think there's additional work that's needed around that. But I do see that there's an opportunity for us as preventive medicine specialists across all of our specialties and subspecialties to move forward and actually help to elevate the health of the public.
Yeah, and just I was flipping about in my wave of the future comment, but I do still think it's the wave of the future. I think it has to be, and my own sense is that it's just the sort of the entrenched inertia of the way the business, quote unquote, of healthcare is practiced that has kind of prevented it from happening yet. There's just no, in my view, no truly sustainable way to address the long-term health challenges that we have if you don't take a prevention first mindset. And so my hope is that it will be specialists within the preventive medicine specialties that will come to the forefront and meet that need. Frankly, if it's not us, it'll be some other group that'll kind of take on that mantle, but someone is going to have to do it because you just can't continue. Again, this is my opinion. You just can't continue to sort of high tech our way into better health.
Yeah,
You have to have those lifestyle changes. You have to have those system-based supports. You have to have that care navigation. You have to have somebody looking at what the gaps are with underserved populations and unmet needs and getting those things to the people who need it as opposed to just sort of the build it and they'll come kind of mentality. So I do confidently believe it continues to be the way of the future. I just don't know how long out the future the future is to when we finally get to that point where we sort of cry uncle as a system and embrace these prevention and population health management kinds of approaches.
Yeah. And I'll only add to that, Dr. Mann, in that I think it requires us all, regardless of what our specialty background is, to work together and to have the patient at the forefront of why we're doing what we're doing, right? No matter what area of life you work in, we all know that there are people who are literally doing it just for the money or just because gets them to the next day, whatever it may be. Having that sense of care around the patient that you're treating, the patient that you have the opportunity to try to impact on their life is where I believe we all have to have that sense, that level of compassion, that level of interaction with our patients to be able to really figure out with them what is helpful for them. And that goes into understanding the social determinants of health and what things they aren't able to access because of wherever they may live, whatever means socioeconomic status they may have. And so, but that's not always where kind of the focus comes from. So I think it's a multifactorial issue, of course, and it's going to take all of us working together to really figure out what is the best path forward. And we're all going to have to, somehow we're all going to have to do that.
We've got just a couple minutes left. I'm going to throw this question out to each of you. I'd love to hear your answers, Dr. O'Hara and Dr. Mann. 10 years down the road, you've been super successful. What do we see in the healthcare system? Or what are the results that you would love to see? Start with you, Dr. O'Hara.
I was hoping you'd go to Dr. Mann first. No. I mean, so if we are looking towards the future and everything has been able to come together and we're super successful in the path forward or the new wave of the future opportunity to get prevention first. I see it as being things where we see decreased levels of obesity, decreased diabetes, hypertension, all the chronic comorbidity type illnesses that are out there. I see children thriving, not, having to be a victim of the society that they live in, but actually thrive in the society that they live in. One of the articles I just came across randomly, not looking for anything like this, as I live in the inner city of St. Louis and have 3 children, but they're like, oh, the success of your child is based on, the neighbors you have. And I'm like, oh, okay. And I mean, my neighbors around here are good, but I do live in the inner city. So, we can hear gunshots randomly at night and things like that. So, in St. Louis, we know St. Louis has a high crime rate. Okay, fine. I see those types of things if we are truly successful, because prevention covers everything, not just clinical care, but the society as it is in our system. So how it functions as well is a part of prevention. I remember being in medical school or residency, and we had research around child safety seats and research around just keeping people from drinking alcohol and doing drugs, the expert model and things like that. So these are all aspects of prevention that we as specialists in preventive medicine, we as specialists in preventive medicine can take on and can impact. Mm-hmm. So if we're truly successful, I see us, I see green trees, grass, butterflies and blue skies in our future.
Yes.
And
fascinating vision
running around.
Fascinating vision. And quickly, Dr. Mann?
Yeah, I can't compete with butterflies and green grass, but that's great. I agree with everything Dr. O'Hara said. Just a couple quick points that are a little bit to the side of that, but that I think are corollaries. One is I think we would have a healthcare system that truly was focused on metrics, outcomes, and how we change outcomes for the better, which sometimes happens, but sometimes we're more focused on how we drive volume or whatever, all those traditional things. And then the second thing, which I think is a spinoff from that, is I think we can get ourselves to a more fulfilled, less burned out workforce. Excellent. And we've seen that in our lifestyle medicine clinic, that we've had folks, providers, staff, whatever, that come through that have worked in other settings, and then they transition and come work with us in lifestyle medicine. They will tell me this is like a new lease on life. I gotten so sort of frustrated with the traditional medical model wherever I was working. And now here I am, and I'm actually spending time with these patients, talking to them about what really is impacting their health and helping them change that. And it's much more fulfilling. And so that's kind of a personal passion of mine, is to see us get to that point where everybody that's working in healthcare leaves at the end of the day feeling like we really were able to focus on the things that matter for changing health outcomes for the better.
Well, that's a great way to finish up the show. So I'd like to thank you, Dr. O'Hara and Dr. Mann, for joining us today.
Great to be with you.
So much. Same.
And back to you, Greg.
And that's a wrap for today, folks. A big thank you to our global audience for tuning in. If PopHealth Week resonates with you, show us some love. Give us a thumbs up on your favorite podcast platform. Share it with your network, and do subscribe so you never miss a future episode. Remember, we're live on Healthcare Now Radio every weekday at 5:30 a.m., 1:30 p.m., and 9:30 p.m. Eastern. That's 2:30 a.m., 10:30 a.m., and 6:30 p.m. Pacific. On behalf of Fred Goldstein, myself, and the crew at Healthcare Now Radio, stay safe, stay tuned, and we'll catch you next time.